It would be good if we could get everybody on the panel. To start, Dr. Park is tied up with a patient right now, but maybe everybody could turn on their. Dr. T-Pass, how are you? It's good to see you.
Yeah, I think this is a plot against MacBooks. I finally found it, nested up on the left, not the right. Here I am in my glorious magnitude.
There you go.
Amplitude.
And a great necktie.
Dr. Ling is going to be on the, he's not going to be on the screen because he can't use his web camera, but we're going to go ahead and start to talk about this a little bit. Dr. Shellington, since you spent time deployed where you didn't have all the resources that a lot of us have just talked about, what's your opinion about craniectomy? Is Dr. Bruce on, by the way? Is he here?
I'm here.
Okay.
I don't know if you can see me, but I'm here.
Can't see your photo.
Can you go ahead and turn
Dr. Shellington, Dr. Bruce is was pretty negative about the craniectomy. You know, he's a colleague of mine, and I don't think he's going to use that very frequently. What would you say to him after having been over there where things weren't too great, equipment-wise?
Well, I guess one approach is to say what happens in Afghanistan stays in Afghanistan. But I think we used the resources we had best available. Dr. Park will talk a little bit. He was my neurosurgeon while we were over there. Would it have been great to put EVDs in some of those kids to see, how the management would have changed? And yeah, it would have. But unfortunately, we had we had a small ICU, and operationally, our main capacity was to take care of active duty service members, and I couldn't necessarily manage kids for the 2, 3, 4 weeks or longer that it might take to get their intracranial hypertension resolved, depending on the severity of the blast injury. And I think it is also, there are some important differences with blast, which I think make it a unique phenomenon and one that's open to investigation, but it's very difficult to do that kind of research in an operational setting. So Min and I, Min would do many more decompressions over there, but it was either that or essentially, watch kids herniate. And so we made the best with the tools that we had. I think that we actually had fairly good results, all things considered, with our lack of capabilities and lack of resources.
Before we go to Dr. Bruce, I'd like to Dr. Ling to weigh in on this. Dr. Ling, what do you think about the craniectomy, having experience with it?
And having to rehab these patients.
Yeah, well, I would say that. So I went over in, I've done 2 deployments and as an intensivist, and I would say that I agree with Dr. Shellington that the hemicraniectomy in Afghanistan and Iraq were extremely helpful. They really were, especially for active duty members who had to then sustain a long flight back to Germany. And when they're in the air, management of ICP would have been problematic. So the hemicraniectomy actually was helpful in that unique setting. And I'll also point out that the hemicraniectomy were done by the neurosurgeons, were done very, very quickly. I mean, a lot of the neurosurgeons, especially Jim Eklund, who was deployed with me both times when I was in Afghanistan and in Iraq, he made a decision to do it early, just because we had to get these guys out of theater. The hard part with the locals, well, the hard part is what Dr. Shellington was really pointing out is the long tail. And in Afghanistan, having visited the Children's Hospital in Kabul and places like that, these kids who had these devastating injuries often don't survive the follow-on care. I mean, it's a very harsh environment over there socially, and so the problem that you have is that you can save these children's lives, but then when you once you send them from your hospital, where do they go? What do they get? And the harsh reality is that many of these children do not survive, and many of them sadly are even abandoned by their families because of the difficulty of caring for a disabled child. So we have to be cognizant of where we are, I think.
So, Dr. Bruce, what would you comment?
Yeah, no, I think that's a very good point. I think that in the setting of, let's say, a traumatized soldier who's got to go a long way for permanent care, then what you're doing is you're trying to make yourself feel better and the patient feel better by hopefully relieving intracranial hypertension. Obviously, in that setting, a lot of people are going to get it who might not need it, but that way at least you're doing the best you can to get people through it. I think in a civilian setting, it's really a very different issue. And we went through this with the Rise syndrome kids, and this came back into vogue for these kids. And yes, we stopped some kids dying because they didn't herniate, but they had devastated brains. So my feeling is that this is an appropriate technique in a situation where you don't have good ICU care, or where that ICU care is going to be delayed.
Dr.
I'm
Tepes.
not what its role is in the States.
Dr. Tepes has had experience. He was an ex-Navy surgeon. And what are your thoughts about this, Joe?
I was just going to kind of pose the question to both Derek and to my colleagues. In the civilian sector, I think it seems to me that if you're considering a rescue craniectomy after day 4, you're probably too late. It seems that this is one of those things that if the patient's injury pattern looks like it can be effectively decompressed, it needs to be done kind of like in the old days when we were training in pediatric surgery, and we used to say, if you think about a gastrostomy, the baby probably needs one. And that there is a very significant time limitation to get the window of opportunity optimized. Doing it at day 8 or day 9 or day 6 because of persistent intracranial hypertension is probably the cat's out of the bag.
I must say I would disagree with that.
Okay.
I think that doing it early, you probably end up with better statistical results, but because you're doing it on people who wouldn't need it. And if you look at how we used to treat head injuries before this, the best results still were with good medical care and removal of masses. So I think that it's something that definitely needs to be looked at. But to say one does it early is, as I say, to include a lot of kids who might not need it, who might have had controllable ICP anyway. On the other hand, to do it later, to some extent, if these kids have responded to therapy over 2, 3, 4 days and then lose ground, you at least have a viable brain that you figure might respond to something else.
And the biology of the timing of maximal edema is such that that's not necessarily going to be visible day 1. It takes a few days for it to progress.
No, I'm not thinking day 1. I'm thinking really day 3, I guess.
72 hours.
Yeah, by that time you're usually in full blossom.
Well, Dr. Tepes, if a child came in with an acute injury, what are the first 2 or 3 steps? I mean, not the whole care, but what can somebody do who's out in an area where they don't have you or these other experts? What are the first couple things that they should do other than provide the airway? Yeah,
basics.
Well, I think the first thing that is often overlooked, and quite frankly, it's even overlooked in our trauma centers, is the pathophysiology of the tsunami of neuroexcitatory transmitters. And, these kids and adults get, quote, resuscitated appropriately, get their CT scan, and then people start treating their neuroinjury. I think that blunting down the excitatory response, optimizing resuscitation, being a good steward of every molecule of free water from that moment on, and then, as I stated, not letting them languish in the system, but getting them up into the ICU setting and established. There's a huge gap, kind of a chasm, and these kids sit waiting for the bed to be ready or something like that. A continuum of care that is focused on precision is something all of us can do, and that would be my response to pretty much anybody asking that question.
What about you, David? What would you recommend?
I mean, I agree. It's just the basics and getting them up to the ICU. Depending on the severity of the injury, and what you believe, then getting an intracranial monitor placed may also help us to guide therapies. I think that the early care is just basic ICU care. It's attention to detail. It's the later care when things get more complicated after a period of refractory intracranial hypertension, because at some point, all you're left with is bad decisions. You either give more pentabarb, you give more sodium, you talk about a surgical procedure several days into the hospitalization, and those are the decisions that I personally agonize over.
One of my problems as a trauma director is that everybody wants to sit in CT scan and do all sorts of CT scans, head, neck, and belly, and they spend an enormous amount of time down there with a bad head injury, which is the worst place for them to be. Do you have any comments on that?
Yeah, well, I would just add. I would add to that, because I think, one of the most common things we see is that patient, and then 20 minutes to an hour into this imaging rodeo, you ask, well, what is the PaO2 and PaCO2, and no one's checked it. So it's attention to detail.
It's interesting. I don't know if Marty remembers, but back at CHOP in the early 80s, what we actually did was put the ICP monitor in the emergency room, so that we monitored the patients through the CT scan. And what led to that was these patients were intubated. We did a study where they went down to CT scan, came up to the ICU, and we immediately took a blood gas. And the intubated, ventilated child who just come from ICP, from being imaged, the mean CO2 was 45. And that was with an anesthesiologist bagging.
So nobody's really talked too much about hyperventilation here. If you don't have the monitor, a patient comes in, they've got an injury, what would you recommend from the standpoint of ventilation initially?
Just the empiric management in terms of ventilation and the empiric management of from hypertonic saline point of view. Talk about that from experience for the inexperienced user. We're talking first 3 or 4 hours of injury.
Who do you want to start?
Let me grab that first, and then the ICU guys can tell me why I'm wrong.
Great. Makes for a good show.
Typically, after there's good ventilation, the ICP is usually not elevated early. And so I don't think there's almost ever a place for routinely assuming that you're treating elevated ICP. I think getting the CO2 down in the mid-30s, getting the head a little elevated, getting the blood pressure at a reasonable level, head in the midline, I think these are simple things to do that are probably going to try to keep the ICP there. It's going to be later on that it rises. And if it's really high at that point, the patient's probably going to die.
Joe, what do you think?
We do not use the 23.4% hypertonic saline unless we have a monitoring system in place for the obvious reason. We have been very, very impressed by the efficacy of that as a rescue bolus, and are fairly quick to use it whenever the ICP goes up and stays up. We obviously follow serum sodiums, but if you remember the Fick principle and you are giving that dose, which is usually around 20 to 30 cc's, depending on the child's body weight, in a central venous catheter, the dilutional effect is instantaneous, and so you're not really giving what is the equivalent of 4 milliequivalents per cc to the patient. Clearly what happens when that elevation goes through the central circulation is some sort of a receptor-driven effect, I guess, or a channel pore gating process, because it does have a response in almost every patient. And the response seems to be better sustained than mannitol. So we're very quick to use it, and regarding all of the potential worries that it will cause significant problem with central myelin pontine myelitis, we've not seen that. As a matter of fact, tracking serum sodium and sodium flux, which is what we're looking at now, as I said, if you just take anybody that gets resuscitated for anything, not just brain injury, a child with a spleen and a fractured femur from being hit by a car, and you do a sodium, or you do a fluid balance on these kids at 12 hours, 24 hours, 36 hours, calculate the amount of sodium that they get, regardless of whether they get balanced electrolyte solution or normal saline, it's way above maintenance. But most of these kids can excrete this. And clearly what we've identified is that these same children, when they have a traumatic brain injury, lose this ability to excrete their sodium. One of the papers that I added to the bibliography is some laboratory work from China that does actually demonstrate that the anomaly appears to be at least partly related to the voltage-gated sodium channels in the axons of the neurons. So maybe that's where the salt is going. Whether this has any effect in identifying a process that will invoke a new therapy remains to be seen, obviously. But clearly, knowing this is going on, knowing it's going on in the first 18 to 36 hours post-injury, at least lets us understand a little bit of the severity of the pathophysiology we're dealing with. So to sum up, hypertonic saline in our experience has been an extraordinarily useful drug. Again, emphasizing bolus. This child that I was talking about earlier is also getting the 3% infusion right now to gently bring her sodium up to more appropriate levels. So I think one of the things that has confused the literature is people don't differentiate rescue bolus versus continuous infusion.
I wonder if Dr. Ling could make a comment. You have a lot of experience in doing the critical care, Dr. Ling. You have a perspective?
I want to actually agree with both Dr. Bruce and Dr. Tepes. First, I want to say about hyperventilation, there's no place for prophylactic hyperventilation, just as Dr. Bruce was saying. No place at all for that. When you use it, it is very temporary. It's temporary both from a physiologic standpoint and it's temporary really from a medical standpoint. It's just long enough time for you to buy you some time to do something else, whatever it may be. The most critical thing about hyperventilation is if you go too low, you can actually worsen ischemia. I mean, there's a clear linear relationship between PCO2 and vasoconstriction. So what Dr. Bruce said was, if you're going to use it, hyperventilate to the mid-30s. Let me say that one more time. Dr. Bruce was, I want to confirm that if you're going to hyperventilate, you're going to hyperventilate to the mid-30s, and that's about as far as you want to go. As far as hypertonic salines, I agree. It has really been a wonderful therapy. The trauma victim, especially kids with blood loss, now you're talking about a volume issue. Mannitol's a good drug, but mannitol's going to actually hurt you because it's going to cause a diuresis. It's going to worsen your intravascular state. So hypertonics are really, really good in maintaining your intravascular volume at the same time pushing up the osms, right? Because, I mean, what is the most important osm in serum? It's sodium. There was a question I see from the chat room that somebody asked, is there a target serum sodium or serum osmolality to begin with? And yes, if you're going to start this, I would say try to get the serum osmolality over 300. And if you want to get a ballpark, you want to be in a serum sodium of 145 to 150. Why do I say that? Let us recall the calculation for serum sodium, serum osmolality. The calculation for serum osmolality is 2 times the sodium plus this, that, and the other damn thing. All right? because the sodium is the big one, right? So it's 2 times the sodium. And so what you want to do is get your serum sodium to 145 to 150. That is the first target. And then after you give your bolus, to reiterate what Dr. Tepes was saying, that gives you time to start your infusion. And then how often do you check? That's what it says over here in this question. I said we typically check about every 6 hours. All right? I wouldn't check any more often than that, but every 6 to 8 hours I think is good enough.
Do you guys have any other comments? I want to try to switch over and present the case that Dr. Park was going to do. And maybe Dr. Shellington, since you and Dr. Park were such close colleagues, will help me with this. But go ahead and, if you would, put up the slide. This is the first slide is the history, if I'm not mistaken. No? That's the wrong strap and go.
Can I ask a question?
Sure. Yes, go ahead.
I have a question for, it's John Crow at Akron Children's. Our worst outcomes for head injuries are patients who have been abused, non-accidental trauma. The question is, do you ever put ICPs in, and do you ever use craniectomy in this high-risk population?
Who are you directing that to?
Really anybody, the neurosurgeons in particular, but Dr. Tepes, Dr. Shellington, our ICU, they have to manage these
Dr. Bruce, why don't you go ahead and take that one?
Okay, I think, yes, I do use ICP monitoring because I think these kids, even although they got open fontanelles, often these kids have incredibly high ICP. And as you know, it looks like in these children, their injury really is an ischemic injury rather than a traumatic one, because so early on they have this ischemic-looking brain. I personally would not use a decompressive craniectomy in that setting. There is, as you know, one report on it, or a couple. There's one report from Denver, and they showed that the kids they did decompressions on for child abuse did indeed have a much worse outcome, both in terms of mortality and morbidity. I think there was one from China suggesting it worked, but I certainly have not used it and wouldn't plan to. But I think ICP monitoring can be helpful.
Can we go ahead and move on to the case here? I hope you can see this. It's an 8-year-old Afghan boy who had a gunshot wound to the head. It's bifrontal with an entry and exit wound that's obvious, a Glasgow coma score of 12, and was intubated before hospital transfer. Dr. Tepes, how would you want to manage this kid right off the bat?
Well, it's a transcranial gunshot wound, and that, of course, is always a problem. And the first set of questions, when just told this is what you've got, is where did the bullet go? Because obviously, if it traversed the venous sinus, then bleeding is going to be a problem. On the other hand, all of us have seen penetrating brain injuries that look awful on CT, but don't have as bad a functional appearance. The CT that's up here now clearly indicates that this child is going to need a craniotomy and some level of debridement of that tissue, and obviously is going to have significant issues with edema. Dr.
Bruce?
Well, I must say I can't see that too well. It looks like there may be...
That's not an excuse. It's not an excuse.
Is that little piece of shrapnel there? I personally would treat this kid with an ICP monitor and close therapy first, and I'd see what happens. If the pressure started to go up, but I would not do an early decompressive craniectomy because you'd have to do it bilaterally, open the sinus, and then you're just going to have the brain swelling right out through the hole because you're giving it more room. It may not necessarily need.
Dr. Shellington?
Well, again, I think I think that how you manage this child in the States may vary with how you manage this child in an operational setting. And I think I remember what we did, but I don't want to misspeak, so I'm going to wait to see the later slides.
Hey, that's not fair. No. Give me an opinion here. Patient's dying.
But here's the thing. I think I know what Min did is a novel solution, and I know that at least on some patients, what he would do is actually go to the OR for decompression, and then on the ipsilateral side of the injury, figuring that was going to be the site of the greatest swelling, and then put in a contralateral EVD in order to be able to offer some form of decompression to that side, rather than giving the child a huge open decompression. Just because those, again, the concern in the operational settings was that those kids could be much more susceptible to later trauma without any overlying skull protecting the brain. So as far as the medical management goes, I was a 3% fan then, and I am a 3% fan now, and I would continue to empirically treat the child with 3% to facilitate getting them through the operating room. I avoid hyperventilation at all costs, and think a PCO2 of 35 is a good place to be until you know that you have intracranial hypertension that you're dealing with.
So you shifted the blame over to Dr. Park, is that right? That's
Absolutely.
a medical guy shifting it over to the surgeon. I get it.
As the surgeon, he gets a much better paycheck and therefore has to take a much larger size of responsibility.
Dr. Ling, what do you think?
I have nothing to add other than the fact that I too would strictly do medical management. The problem with the hemicraniectomy, and I'm going to say this again, you just said he's an 8-year-old Afghan boy. Who's going to do the cranioplasty? Right. I mean, fundamentally, who's going to do the cranioplasty? Where's he going to get it? And it ain't going to happen. So that almost tucks your hand. There is a school of thought, just to put it out there, that some surgeons might go in and do a craniotomy and a partial frontal lobe decompression, figuring that there's going to be a swelling in this case. I'm just saying, and I'm not going to say names, but I've seen it done in theater for these patients, recognizing that there's very limited things you can do because you have almost no outpatient follow-up once you send this kid out.
Can we have the next slide, please? So this youngster underwent a craniotomy and a craniectomy. Next slide. And you can see here the extent of the craniectomy. The bone flap, I'm not sure whether he was able to reconstruct this while he was in theater. Next. Go ahead. Go ahead.
No, I was going to say we did two of the 13 kids who came in who received decompressions while we were there. I recall that we had 2 patients come in, and there may have been a third who came in from an earlier surgeon. We in Kandahar, we essentially approached it as well. We created the problem by doing the craniectomy, so we would offer the solution. So if the parents were able to get back to us, and there was oftentimes large distances and hazardous travel involved. But if we could get them back to us, our neurosurgeons would actually offer that to the patients.
So this is Dr. Park, who is a commander in the Navy and has deployed several times. He put together the patients that he's treated, which is 13 patients, 9 boys and 4 girls. The age was approximately 7 years of age. You can see he has 11 survivors that he knows of because of the follow-up, as Dr. Shellington and Dr. Ling have said. 2 deaths from this, from you can see right there, multi-organ failure and herniation, and then 2 cranioplasties where these kids apparently have done reasonably well. I'd like to give each of you one last shot at what guidance would you give to that young surgeon or nurse standing by the bedside when they come in? What's the first thing that you want them to know? Dr. Ling?
If this Afghanistan, my thought would be is that we have to, the triage issues are going to have to be done as early as possible, and managing expectations in the environment that you're in. So that is going to, I think, dictate your therapy as you move forward.
Dr. Shellington?
Don't fear hypertonic saline. I think it's a very useful therapy. There's some controversial literature out of there, but if you need to buy yourself a time to make decisions, we will have a study out from this institution in a few soon, hopefully, that the sodium levels, problematic effects from sodium typically don't occur up to a serum sodium of 165, so you have a little bit more leeway than what you may think to push your sodium up to get your ICP down while you figure out what you want to do to make a decision.
And now we go to the surgical opinion. Dr. Tepes?
Well, I mean, the one thing that appeared to me in presenting this case, this is a child who had a dirty bullet go through probably a headpiece and drag material into his brain. When I recommended that he be debrided, I wasn't really thinking of craniectomy as much as just debridement, kind of like I think what was done. I think I would agree with what David said. You know, if you are in an environment where you have no support, again, this in a civilian environment, then you want to stabilize and optimize the child to get him to a center where this can be managed. If you're in a center, then the issue of a contaminated cerebral parenchyma that is going to swell and become infected has to be considered.
Dr. Bruce?
Yeah, I think it's totally dependent on the setting. I mean, I think if one doesn't have ICU, if this is a kiddie that you're not going to have anywhere else but in the front hospital, then you do what your gut tells you. If the kid has a decent neurological exam at this point, I think certainly no one would give you a hard time about having done a craniectomy, because if you don't have any way to monitor ICP and any way to treat it, that makes the surgeons feel they've done what they could. Whether it actually make any difference to the kid's outcome or not, I think is a different question.
Gentlemen, thank you very much. It was really an outstanding, exceptional discussion today, and I think you've raised our level of understanding, raised our level of what we need to think about differently. And so thank you so much for taking your time. I know people all over the world are very appreciative of what you fellows have done. So thank you so much. Appreciate it.
Just before we quit here, before we go to break, I lost my little arrow there. But I want everyone to please visit the booth and download all the documents that all the talks that you saw here. And we'll be returning in about, 15 minutes. 15 minutes, and we'll return for the third portion of today's symposium. See you in 15.
How you doing, Dr. Moore? Welcome back, everybody. We appreciate the fact that we have one more section to go, which is going to be really exciting, really some interesting procedures we're going to talk about. During the break, Dr. Min Park called in, and he was very concerned about the fact that he didn't get a chance to make his point because of the controversy that was stimulated on craniectomy. And so we're going to give him 2 minutes to state his point before we move into the next section. Dr. Park.
With apologies to Dr. Moore.
That's right. With apologies to Dr. Moore, which will be with you in 2 seconds. Dr. Park.
Well, thank you very much for giving me the opportunity to talk. I apologize for the absence. But just quickly, when we're deployed in Afghanistan, we were faced with these pretty traumatic brain injuries. You really have to think hard about what's the best thing to do. And I think it's a very personal decision that you make, knowing that the long-term survival for patients with severe injuries in that situation, and with limited medical resources, may necessarily be low. But in my opinion, I tried to do everything possible with the resources we had. Again, knowing that follow-up and long-term care is a significant issue. It's particularly gratifying to have at least 2 patients come back needing cranioplasties, and at our facility we were able to perform that. I do understand that outside in that environment that's incredibly difficult to do, but for us and for me personally, I felt that the best thing was to give them every opportunity to survive at least the initial injuries, and then hopefully through one way or the other they would be able to find the necessary rehabilitation and support to potentially have a good, meaningful survival. And at least in 2 patients we were able to do that. Thank you very much.
That's fantastic, and thank you for taking the time to participate with us. And I'm going to